Namaskar, myself Dr. VIPUL GURJAR. I am practicing surgeon in Vadodara as well as I am a professional head of the Department General Surgery, Vadodara. Today we are going to discuss about the problem of MIPH surgery and its trick, how to or it's a solution, how to do this MIPH problem, uh, come out of that problem. What is the most common starting problem once we are starting the MIPH? First problem we get is the loaded stool in a anus. See, we are doing the resection and anastomosis of mucosa, so we need to be a very clear environment to minimize the surgical site infection. That's why I am giving that much importance about the anal clearance or the anal local part sterilization in MIPH. If it's the after the anesthesia, if you find out that there is a stool is loaded, so how to clear? We can't do the postpone the surgery in the after the giving the anesthesia. So it is better to do the bowel preparation previously, but if it is not happen, then you use a TURP set speculum in the left hand. Put the speculum at the multiple side, 3 o'clock, 6 o'clock, 9 o'clock, 8 o'clock position. 1 liter of normal saline attached with the TUR set, you can get a 95 to 100 percentage local site clearance. Second problem, the fixation of a circular anal device. Sometimes we are not able to push this circular anal device in a anal canal. This might be due to the chronic fissure, chronic fibrosis, or because of the narrow pelvis in lean and thin adult male patient. How to deal? Before that, I want to make you clear that there is a two technique. One is the push technique and second is the pull technique of insertion of CAD. Push technique is always best. So now how to do? If this happen, this is a problem, then first you do the sphincterotomy if it is a case of a fissure along with. If it is not there, then put the dilator, put the two finger inside the dilator of the MIPH set. Then pull down at the 6 o'clock position, that makes the sphincter more relaxed. Then take a CAD over the dilator and whole sets should try in a screw manner that accommodate the anal canal. If it is not happen, then apply the 4 Ellis forceps at 3, 6 and 9 or 12 o'clock position. But please try to avoid this thing because this Ellis bite may cause a mucosal tear or perianal skill injury, and that will become a painful. So you just stretch the Ellis and try to push further CAD in screw manner. If it is not done inside that, then you take a anal verge suturing 3, 6, 11, 12 and 9 o'clock position. This long suture pull outward and then try to accommodate the CAD instrument. 90% this CAD may fix out, but beware that you must see the only and only pinkish mucosa after putting a CAD. If you are able to visualize any anal verge or pile mass in anal canal after putting a CAD, then the disaster is 100%. So the CAD fixation is the one of the most crucial step for the MIPH. After the pulling of this anal verge with the suture and putting the CAD is known as a pull technique. But then you should not tie this suture directly the hole of the CAD. Try to remove the suture and fix the perianal skin to the CAD. Another problem of MIPH is inadequate or non-circular donate. To get this donate, what are the solution? Take no lower down or not higher up the suture. That means the half anoscope, in between that half anoscope is 2 or 3 marking are there. So you take a purse string suture between 2 to 3 marking, in between 2 to 3 marking. As well as to get the circular donut, it is better to practice you mark with the cautery circular in manner, so your suture line must be in a circular. Many times if we are not doing this marking, we are vary the suture line and we are not getting that circular clockwise purse string. Another cause of inadequate donate is the suture lock. That means after the purse string, starting the purse string suture, and when you complete this suture, your suture will not give the shoe sign manner like position. That means if you pull this suture after this thing, it may lock because of the inadequate surgical technique of doing a purse string. So to prevent this suture locking, you must add one suture or a counter suture in a 9 o'clock position. Here I want to say there are the two method of counter suturing. One suture many surgeons are taking after the purse string, they will take a 9 o'clock additional bite to pull the mucosa. No, this is for the pulling method, but to prevent the locking, you had to add one loop of a suture in which purse string suture must pass out at the 9 o'clock position. So after this completion of the suture, you have a one hand counter suture and on other hand your purse string, and then you need to do like this shoe shine manner of MIPH. This is my term, that is shoe shine manner. If you are doing well, there won't be a locking of this purse string suture. Then also after taking, you have to put a finger inside. There should not be any exposed a prolene suture material of that purse string. If it is there, then you may get inadequate donate because that mucosa of that part will not come inside the staple line. So this is also one method that you have to palpate this suture with the finger. Another problem of is the inadequate donate is too much pulling of purse string loop while closing the staple. No, it is not that much required, just required a gentle pulling that include the mucosa inside the staple. So there is no extra space. If you are pulling too much mucosa, then it may lock the machine and that will create a problem of during the reopening. So the gentle pulling is the only required. Another tip, while we are putting a open staple, it must be the above the purse string suture and it moves very easily in surrounding manner. If it is not moving, then it may getting stuck somewhere. It is not a right thing. Then another problem of MIPH is the oozing from the staple line. This may be it may be the minor one, but you can prevent during your surgical technique. That means after the closing of the staple, you may or you must wait for the 3 minutes. During that 3 minutes, all the fluid from the serosa and mucosa may disperse and adequate compression will be get. As well as after the firing, you must wait for the 30 second to 45 second to get adequate hemostasis. That will may helpful after the firing of the staple. Another problem after the firing of staple line is to stuck your open staple. That means it is difficult to remove the staple, and sometimes we are feared that our staple line is may injured. So there are the two technique. The most of surgeon are following that we should open 1.5 circle. No, this 1.5 circle definitely stuck or strike with the CAD. No, there is only two method. One is the half circle. You just open the half circle, rotate the whole staple in a 180 direction, and you can get easily removed. If you are not following, then don't worry. Remove, reopen all the stapler, so you can directly visualize your anvil and the staple line. So without striking it, you can remove easily. So it is only the half circle relock or the full relock. There is nothing like a 1.5 relock. Then after, the last complication is the oozing from the staple line. If there is a oozing, don't use a cautery. Just give the pressure. Sometimes or most of times 95 to 98% this type of oozing may stop. Many people are taking a multiple suture for a wound dehiscence, staple dehiscence, but in a practice it should not be done. You can do when your odonate is not a circular, then you have to take a multiple stay suture to prevent the staple dehiscence. But if it is bleeding is happen, bleeder is there from the staple line, then use a 27 mm 5/8 circle vicryl 20 suture in a Z or X manner with a long needle holder of 8 inch, and try to take with the curved needle holder. See, these all the sentence may helpful. That means curved needle holder, 8 inch long needle holder, as well as 27 mm vicryl 205 circle. These are the suture is best to take during the anal canal surgery. Now the postoperatively. The postoperatively sometimes there are a chronic pain in a MIPH, or urgency in a immediate urgency of stool in MIPH. This urgency mainly occurs because of the we are resecting the mucosa, which is having a sense receptor of defecations sensation. So it may happen, but it may go win off after a few days or the month. Sometimes the patient having a pain, immediate pain. This immediate pain, it is mainly because of the instrumentation, artificial tearing of mucosa. So you required or you have to treat like a fissure only. If the patient having a persistent chronic pain, then you do the PR every 15 days, and you ask during the examination, you will feel a tenderness over the staple line. In early days of the MIPA, there may be a chance of submucosal abscess. then do the MRI and do the treatment according to it. If it is not abscess, then the patient having a chronic pain after 3 to 6 months, then it is known as stapler pain, because of the pain of this staple line. It may take some deeper bite, then you may require of under anesthesia and removal of the staple line. Another complication is the staple line stricture formation. Staple line stricture formation mainly occurs because of the tissue response and 10 to 20% because of the surgical technique also. But the tissue response is the main problem. Sometimes it may be the early and the soft tissue stricture. You have to get the patient in a follow-up every 15 days, do a PR examination, and if it is a softened one, it will reopen. And don't use a stool softener, or that is the laxatives. You advise a patient to take a normal stool softener, the bulk forming stool, rather than the laxative. So it may dilate this soft stricture easily. If patient having a chronic anal stricture, staple line stricture, then what to do? Then you have to do the multiple Mercedes band incision under anesthesia, and then the chronic dilatation, that means a regular follow-up dilatation patient has to do every day. But to remove this chronic staple line stricture, you don't use a forceful dilatation. It may tear, it may cause a more mucosal injury and rectal injury. I would suggest a sharp cut 12 o'clock, 4 o'clock and 7 o'clock position. As well as to remove this stricture, a staple line stricture, the Chiute proctoscope, Chiute surgery or any dilatation will not help. Any flap surgery will not help, because the staple line stricture, it is quite higher than the anal verge. This flap surgery is mainly built mainly for the anal verge stricture, not the mucosal stricture. So that's all for about the MIPH problem and its a solution. In a next lecture we will discuss something else. There are lots of video of academic regarding the anorectal surgery in YouTube. You may contact go through the anorectal YouTube my channel. You may help. Thank you very much. Bye.